Welcome everyone. Thank you for finding time and joining us for today's webinar. My name is Louis Yang from Biomechanics. Biomechanics is the class-leading manufacturer in orthopedic technology. Today, our webinar's topic is calcaneal fractures MIS technique, which will be presented by 4 speakers. Dr. Michael John Gao-Ming from Australia, Professor Zhongming Shi from China, Dr. Mate Andoshek from Slovenia, Dr. Jia Liang Hong from Singapore. According to our webinar agenda, now I'm going to invite Mr. Justin Lowe, the CEO of Biomechanics, to deliver a brief welcoming speech for all your participating. Thank you.
Hi, every doctor. Welcome to this webinar. I'm Justin Lowe, the CEO of Biomechanics. Biomechanics is a group company sitting in Xiamen, a magnificent, beautiful city around the southeast coast of China with outstanding humanism. Biomechanics is a publicly listed company in China's stock market. As of today, the market capitalization is more than 6 billion US dollars. So we are the leading producer for orthopedic implants for trauma, spine, joint, sports medicine, as well as for pediatric orthopedics. We have huge, massive production facility with sophisticated equipment and a state-of-the-art technology. As you know, the whole world has been deteriorated by the COVID-19 pandemic. We have to stay indoors for. It is fantastic also that we can go through the internet and using web tools, helping gathering us so easily to reach from each other just by a click. So being a doctor is not an easy job. It is a lifelong learning and a practicing profession. Learning never ending. Today, this is my great pleasure to have 4 very experienced surgeons here being with us as our distinguished international speakers for this webinar. Today's topic is minimal invasive surgical treatment for calcaneal fractures. As the Chinese proverb says, 1,000 miles journey begins with first step. So that means feet are so important to us. Hope all of you will enjoy the topics and engage in professional discussion. Thanks all of you for being with us. And also, I hope you and your family are safe in this period. Thank you very much.
Mr. Justin Lowe, thank you for your welcoming speech. We are excited to have you all joining our webinar today. Just a little housekeeping before we get started. We want to help you get oriented with our connection interface. If you have any technical difficulties, please type them into the chatting box of Zoom panel that you will see on the lower left-hand side of the screen. We will do our best to help you work through any difficulties you encounter. Additionally, throughout the webinar, we will be compiling the questions that you may have about the lecture. Please enter those queries in the chatting area of Zoom panel as well. At the end of each lecture, we will have 5 minutes for a short question and answer section to address your questions. For your information, the participants can leave the contact information or contact us by email, course@biomechanics.com. We will send you the webinar record to you as well as the upcoming webinars. For the purpose of this webinar, we have elected to mute all participants, so please utilize the chatting area for all communications. Now, without further ado, we will turn the time over to our speakers. Our first topic is minimally invasive calcaneal fractures fixation, presented by Dr. Michael John Gao-Ming from Australia. Just a kind reminder, please don't hesitate to type all your questions for speaker into the chatting area. We will connect and answer them after the lecture. Dr. Gaoming, it's your turn now. Please help to share your content and screen by click the green icon. Share content. Thank you.
Thank you very much. It's an absolute pleasure to be here talking to you tonight. And I hope everyone around the world who's listening to this is staying nice and safe in these difficult times. So what I'd like to talk about is something that I feel really passionate about, and that is minimally invasive calcaneal fracture fixation. I've got just some acknowledgements. Dr. Greg Berry, who was my fellowship supervisor for my trauma fellowship in Canada, and Dr. Christian Rodemund, who this is his minimally invasive technique that I've been utilising. In terms of background, I am an orthopaedic surgeon trained in Australia who has a particular interest in foot and ankle surgery and trauma. And when doing my trauma fellowship in Canada, the surgeons there were particularly keen on minimally invasive calcaneal fracture fixation. And through that process, this is where it's led me today. So we'll be talking a little bit about calcaneal fractures this evening. And when I first learned how to fix calcaneal fractures, it was via the technique that you see on the left here with the extensile approach and large soft tissue dissections, high rates of wound complications, having to wait until soft tissue beds were acceptable and would allow you to perform large operations, which meant that often fracture reduction was difficult in partially united fractures, and I was finding myself that I had to osteotomize fractures, and it was a very challenging operation and certainly not something that I really looked forward to. So for me, the indications for performing a minimally invasive technique for fixation and reduction and fixation are really displaced calcaneal fractures that are suitable for a minimally invasive technique that ideally I can get to within 3 days of their injury. And this technique is so minimally invasive that I'm very happy to do this irrespective of the amount of soft tissue swelling that this patient has, because really what I'm trying to do is restore the normal anatomy of the calcaneum and the heel, and that's certainly beneficial for the soft tissue envelope, as evidenced by this picture that you see here on the right, where the tuberosity fragment is tenting the skin, and that's a person who I'm really concerned about, as there's an area of threatened skin there. So for me, I think it's really important that that these patients get set up properly, and you need to make sure that that you can actually obtain adequate intraoperative radiographs. For me, I like to place a tourniquet on the thigh, place the patient in a lateral position, and then bring them as close to the back of the bed as possible, and that allows their leg to dangle out in free space. I then use a support where I can place the calf, and it allows me to get the radiographs that I need to do. So when you're positioning the patient, there's really only 3 X-rays that you need to get. One of those is the lateral X-ray, which you can see the radiographers performing here. The second is a Broden view performed with the image intensifier in approximately 30 degrees of rotation. And then the third X-ray is a Harris heel view. And This is performed with the image intensifier parallel with the floor. And as you can see, I've got my registrar here who is holding the knee in some slight extension to allow a better X-ray of the calcaneum. I find that this soft tissue support that you see here that allows the knee to be extended slightly, it really has made it a little bit easier to get that Harris heel view. And that's what I'm trying to demonstrate with this picture. So rather than having a U-shaped gutter which really locks the lower leg or the shin in position, a more flat style bolster does allow a bit of knee extension and a better Harris heel X-ray. This is a case of mine. So what we're looking at is the lateral X-ray, and what I like to do is, using image intensification, I mark on the site that I'm going to place 2 traction pins, and these pins are inserted from the lateral side directly through, so that they protrude from the medial side of the foot. And the location of those pins is one centered in the talar head, and then the second is centered in the calcaneal tuberosity, so that the axis between those 2 points is perpendicular to the posterior facet of the subtalar joint. After marking these 2 landmarks on the patient, as you can see with the picture on the right, what I use 2 2mm K-wires that then get passed through the foot, and the K-wire that is passed through the head of the talus is passed perpendicular to the foot, and then the K-wire that is passed through the tuberosity of the calcaneum is passed perpendicular to the axis of the calcaneum, as you see it on the Harris heel view. And with a typical fracture pattern that we see with the calcaneum, we see that these are usually inverus. And so the wires are divergent on the lateral side and convergent on the medial side, so that when I place the distractor on, there's a greater amount of distraction on the medial side, which corrects the varus of the heel. We've got this distraction device, as you can see here, which is placed on both sides of the foot. And then the distraction is placed across the 2 pins, of which there's always more on the medial side, until those pins become parallel. And then as you further increase traction on those pins, it causes the heel to reduce via ligamentotaxis. So you can see the displaced lateral wall on this image here. And then as you start to apply soft tissue traction via the pins, you can actually see that lateral wall reduces in the tuberosity position, and the varus is restored into a more anatomical position. After doing this, the next step is to reduce the articular surface. And I like to do this via making a small incision under II guidance on the lateral side of the foot, at the approximate point that I would like to introduce a tamp in order to elevate the articular fragments. And I do that by marking on the foot, making a small 5mm incision, and then I like to use the countersink drill for one of the screws that I'll show you in the moment, in order to create a small hole in the lateral inferior wall of the calcaneum, and that allows me to introduce a fine instrument. I've moved away from using the tamp, and in actual fact, the instrument that I've been using the most is believe it or not, the depth gauge for the 7mm cannulated screws. Because there's a significant amount of distraction that's being placed across the subtalar joint, the reduction of these articular fragments is usually quite simple and really requires very little force, because all of the joint reaction force has been taken off by the distractors. Then once I've elevated those joint fragments and confirmed that reduction on both the lateral X-ray and on the Broden view, that the view that's taken at approximately 30 degrees, I pass a single K-wire from the lateral side of the foot at the tip of the fibula, across the articular fragments, and then into the constant fragment, the sinus tarsi. Over this, I then place a cannulated screw, and then depending on the particular fracture configuration, I would usually place two large 7mm fully threaded screws, so that they raft the sinus tarsi and support the articular reduction. And this is what they look like. Seen here. Following this, I close the wounds with a non-dissolving nylon suture. I place them in a back slab for 2 weeks, and then at 2 weeks I review the wounds and then place them into a cam boot, non-weight bearing, until the 6-week mark, and with x-rays to confirm radiographic union before allowing weight bearing. This is an example of what the incisions look like at the 6-week mark, and you can see that even in this gentleman who is a type 2 diabetic, what I would consider a high risk patient for a calcaneal fracture, because of the very small size of all of the wounds, it's very unlikely to have any wound issues. Some of the challenges for me throughout this process have really been trying to find equipment and to perform the operation that I've been trying to do. The very first one of these I used a femoral distractor, which did provide a good reduction, but was very bulky and very difficult to use. I was then able to look through the double medical catalogue and find some instruments that I thought would be suitable for performing this type of operation, and they've since become available, and we've now put a little kit together which has got the distractor, the screws on it, and it is certainly much easier. Because the vast majority of this operation is really performed percutaneously, it does require a significant understanding of the calcaneal anatomy, and it also requires a significant understanding of the fracture morphology. I think the most difficult screw to insert is that goes through the articular fragments and into the constant fragment. And I think it's really important to understand that the trajectory of this screw in the coronal plane is approximately 30 degrees anterior. So when you're inserting this screw, you do need to be aiming anteriorly towards that sustentaculum in order to get the screw into the correct position. And it is important that you check this K-wire on both the Broden view and the Harris heel view, because if you aim this screw too inferiorly, you do place the medial neurovascular bundle at risk, and you have to be careful of that. The other thing that I think is certainly worthwhile and something that I've found particularly useful when I first started doing these was asking for a 3D reconstruction of the calcaneum with the surrounding bones removed from that reconstruction, so that you can understand the fracture morphology as you see it in front of you, and you can plan how you intend to move the individual fragments into their reduced position. And I think having a good game plan and having studied that CT scan before you start the operation certainly it makes the first few of these that you do much simpler, given the complex calcaneal anatomy. I would like to share some cases with you, just so that you can see some of the different fixation techniques that you can employ, and just to give you an idea about some of the reductions that you're able to achieve using this technique. So I don't always just use a single sinus tarsi screw. I think in the setting of large joint fragments, it's often beneficial to get 2 rafting screws across the articular surface. And you can see the strength that this technique has in terms of reducing the varus of the hind foot just by applying traction across that tuberosity. Another case here, and fairly significant lateral wall blowout and shortening of the heel, again brought out to length quite nicely. And the reason I like to use the fully threaded screws is that these are non-compressive, and they really work to maintain that reduction that you've achieved with your traction device. So in the top right corner, the screw that goes from the tuberosity towards the subtalar joint is really working to hold those 2 pieces of bones apart, reducing the lateral wall via ligament ataxis and allowing the calcaneum to heal in an anatomical position. Again, fairly significant impaction that's distracted really nicely using this technique, and fairly impressive correction of the varus that happens at the heel. Not all calcaneal fractures have an intra-articular component. This is a fracture that was extra-articular at the subtalar joint, and so it doesn't need to have that rafting screw, but the 2 screws certainly do hold the calcaneum in an anatomical position to allow bony union. For patients who have almost like a tongue type fracture pattern, starting the screws in that proximal fragment and aiming them inferiorly not only rafts the articular surface at the subtalar joint, but it also provides adequate fixation for the tongue fragment. In terms of some of the complications, I'm quite happy to do this on all patients: smokers, diabetics, patients who have significant soft tissue swelling. And at this, to date, I haven't had any wound complications, and I think that speaks to this technique and to the very small incisions that are required to obtain and maintain an anatomical reduction. And I have had one neurological injury, which was a patient who had significant calcaneal varus, and as I applied the traction on the medial side of the foot to correct that varus. I'd actually got to the extent that the skin or the soft tissue on the medial side would allow, and I had to make a small incision in the skin, and I think I have picked up a damaged cutaneous nerve when I did that. So they've had a little bit of paresthesia, but no ongoing neurological symptoms following that. In terms of advice for people who are interested in taking up this technique, pick an easy one first. Pick a Sanders 2 or at most a Sanders 3 with preferably one large articular fragment that can be easily reduced. Do it early. The strength in this technique is its ability to allow a simple reduction of a difficult, complex fracture. By doing it early, you are allowing those the fracture fragments to be mobile and easily moved. And if the longer you wait, the less you are able to distract the calcaneum, and the harder it is to maintain that anatomical reduction. And in someone who has soft bone, you do run the risk of cutting out the wire in someone who is you've left for over a week. I try to get a 3D reconstruction for all of the fractures that I ORIF, so that I have an understanding of this, the unique fracture pattern particular to that patient, and so that I'm also able to plan my screw trajectory and insertion. And I like to have looked at that beforehand so that during the operation, I'm merely just performing my plan rather than trying to determine how I'm going to reduce a fracture while the patient's anaesthetized with a tourniquet on. I think it is very useful to have a model of a foot when you first start, so that you can look at the anatomy of the calcaneum and you understand where you're aiming your screws at. And as I said before, you need to have planned your reduction and fixation before the patient's asleep and anaesthetized. You want to spend your surgical time performing your preoperative plan rather than trying to figure out how to reduce a fracture in an operative setting. In terms of where we're heading to next, we've been working on the large screws in order to make them better forward cutting, less compressive and more supportive of the surrounding bone. We've got a radiolucent retractor in the works, so that you don't get the interference with the image intensifier when you're assessing your articular reduction. And we're also looking into different reduction tamps in order to assist with articular surface reduction. I think that's my time up. I'm very happy to open it up to questions now.
Thank you, Dr. Gao-Ming. We will go ahead and take some time for questions. Here are some questions we have collected during the lecture. So now my colleague will project the questions. Okay, so Dr. Gao-Ming, can you please help to answer the questions on the screen? Thank you.
Okay, so question one. Let me have a look at it. The requirements for, as I said previously, for me, there's nothing that will make me not perform this technique. So I don't mind if the patient has large amounts of swelling. For me, I'd rather get to these patients earlier so that I can successfully reduce the fracture, because I know with a series of very small, up to 5 millimeter, 6 millimeter incisions that even with significant soft tissue swelling, that they will heal. And then the second question, any type of calcaneal fracture can be treated with minimally invasive surgery. What I think the Sanders classification really reflects is the difficulty that, so a Sanders 2 is the easiest, a 3 becomes harder because there's 3 articular fragments that you need to reduce, and then a 4 is the most difficult. Now, it's not saying that you can't do a Sanders 4 minimally invasively. It's more challenging, and you have to watch each individual fragment on that Broden view come into a reduced position. So it is certainly more time consuming. But for the first one that if you're going to try this technique, I'd definitely start with the Sanders 2.
Thank you, Dr. Gao-Ming. It looks like we have covered all of our questions. So, Dr. Gao-Ming, is there anything else you want to cover before this lecture wrap up?
No, I think that's everything I'd like to say. But this has been one of the best techniques that I think I've learnt within the last 5 years, and I haven't looked back.
Thank you, Dr. Gao-Ming. So now let's move to our second lecture. So in the next, Professor Zhongming Shi will present a topic, minimally invasive treatment of calcaneal fractures with the sinus tarsi approach. Just a kind reminder again, if you have any questions about the lecture, please don't hesitate to type your questions into the chatting area. Professor Shi, now is your turn. Please help to share your content by clicking the green icon, share content. Thank you.
Good evening, everyone. Thanks to Double Medical for giving us the chance to get together. So this is my topic, minimal invasive surgery of calcaneal fracture with the STA for the sinus tarsi approach, and Zhongming Shi from Shanghai. This is our experience. It's also our learning curve for calcaneal fractures. Before 1998, we just do the close reduction.
Excuse me, Professor Shi, please allow me to interrupt you because now we cannot see your desktop, your screen. So
screen, no?
Yeah, so now we cannot see your PowerPoint. So
okay,
can you?
I will try again. Yeah.
Now I can see your video, but can you click the 共享屏幕 in the below there's a 共享屏幕, so you can share your PowerPoint.
Let me try. Okay.
Okay.
So, is it okay for the screen? No.
Now I can see your desktop. So 我可以看到你的桌面. So
okay,
I think you can.
Now is it okay?
Yes, and yeah, thank you.
So sorry everyone. Thanks to Double Medical for giving us the chance to get together. I'm Zhongming Shi from Shanghai 6 People's Hospital. So my topic is just for the minimal invasive for the calcaneal fracture with the STA. This is our learning curve. Before 1998, we just do the close reduction. And from 1998, we will just do the OIF with the lateral extensile approach with the big plating. And 10 years ago, we do the minimal invasive. And since then, we have done a lot of calcaneal fracture with a minimal invasive approach. And from 2016, we also do the arthroscopic assisted reduction. And last year, we began to do the robotic surgery for minimal invasive. So we published our paper in almost 18 years ago for the calcaneal fracture with a Y plate. At that time, we used the Lima plate. This is from Italy, and also from for the Sinus company for 8 years ago, and for the Biomechanics plate 16 years ago. And we do the first generation locking plate almost 14 years ago. And we published our paper about the minimal invasive since 10 years ago. And also we have the patent for our locking plate. And last year we began to do some research for the robotic surgery, also do for the calcaneal fracture, but it is a long learning curve. So why we changed over time? So because since this is all those papers published in almost 20 years ago, what happened? So this is a paper about the management of the calcaneal fractures, what we have learned over the years. And this is a very important paper published by the Roy Sanders, and also a series of papers about the lateral approach. And in 10 years ago, back from Canada, he published his paper with the conservative and also the operative treatment. So the results is the same for the two groups. So if without the working compensation, and so this gives us some, we just wonder about the results of the calcaneal fractures. So too many champs after the 20 years experience. So what about the goal of the surgery, which is important of the surgery, the reduction or the approach or the choice of the internal fixation. So what about the reduction? The most of the case we found in the clinical, we found just no reduction. It's just the open and the internal fixation, and which is important for alignment. We find also a lot of cases of varus deformity, and also some cases for valgus deformity. And a lot of approach, although we have educated more than 20 years, we still find that this is not a standard lateral approach, and a lot of problems of the approach, the infection, and also the problem of internal fixation, the screw direction and the length of the screws, and the non-union of the fracture, and the breakage of the plate. So this is the paper of evidence-based level 2. I think a significant relationship between the deep infection rates and also arthritis, and just indicated the need for specialized institution trauma care to improve outcomes for the operative treatment of calcaneal fractures. So, and also this paper suggested for this is experts only for calcaneal fractures. So still a lot of arguments for the such kind of problem. So the first is approach is should be open or minimal invasive, and what about the reduction, which is important, the alignment or the also the distortion of the articular surface, and how to choose the internal fixation. So why we do the minimal invasive? We have the common sense that the surgery is the good effect, good treatment for the calcaneal fractures, and but there's a lot of complications for lateral extensile approach. And the problem is a soft tissue problem for the edge necrosis, and maybe some case of infection or osteomyelitis. That will be a disaster. And also some small problem of the union of the cartilage and infection. So although we have educated for a long time, still some doctors will apply this is irregular approach for the bigger lateral approach, and maybe it is difficult for the late reconstruction of the subtalar arthritis. And this is a very important paper published more than 6 6 years ago in BMG. The conclusion is surgery is not suitable for some cases of the calcaneal fractures. So this is 20 years male. This is the young athlete. We found from the lateral view, we found that the intra-articular fractures and the alignment is so not so bad. And this is sagittal view. We found also that decompression fragment. And from the this view, we found that this is Sinus type 2, maybe just a type 2A. So we found some confusions. This is a simple fractures, just a Sinus type 2, young and active. So what kind of treatment should we choose? Conservative or surgical, surgery? So if conservative, what about the stiffness and sometimes the post-traumatic arthritis? So if we would do some surgery, is there still, we should try the traditional lateral approach with a big plate? So the paper publishing in Journal 8 years ago just talk about the future. So the less invasive surgery, arthroscopy and the 3-dimension fluoroscopy are very important for reduction and for the treatment of the calcaneal, maybe in the future. And since the paper more than 27 years ago for Roy Sanders, no change for the principles. So the goal of the surgery is for restoration of the 3D construction of the calcaneus. The alignment is very important. We should also reduce the articular surface and the good internal fixation. So the final choice for such case, we choose the minimal invasive. This is my first case. We choose the modified sinus approach. This is more horizontal and is maybe just less than 5 centimeters. This is directed invasion of the subtalar joints. And also we can avoid the complication of the lateral approach and avoid the stiffness of the subtalar joints. And sometimes we don't have the arthroscopy, and it's easy to direct find the fragment and reduce them and temporarily fixed with the KYs. Then use the 2.7 small fragment plate. This is a non-anatomical plate, and we also use the 4.5 axial screws. This is very important for the alignments. And then we also apply the 3-point fixation principle for the sanitasi sustained tacular. This is a constant fragment screw. Is very important, and maybe 70% of the intra-articular surface will involve the calcaneal cuboid joint. So we should reduce the calcaneal joints and also the tuberosity. So this is our choice. We use a 3D reconstruction. We use a Rafting plate for the articular surface and the axial screws for the alignment. Then we stabilize of the medial and the lateral column and the articular joints. This we call the 3D reconstruction. And this is 35 years male. We also see this is tongue type. This is coronal view because this is Sinus type 2, but sagittal view with small, this is a depression fragment. This may be called the Sinus type 3. Yeah. So we do the STA approach, then find the fragment, decompression fragment, then reduce them, use the small screws, also the 2.7 mini fragment looking plate, how to evaluate reduction intraoperatively is very key. So you can use the 3D CT intraoperatively. So this case, after the reduction and the plating, we just find that the articular surface reduction is good. And also the sagittal view. So some doctors suggest for the arthroscopy for the reduction of the calcaneal fractures. This is a result from a German published more than 18 years ago. And also this is Zhongqi Wai from Singapore also published their experience and said this subtalar arthroscopy and the fluoroscopy is the best of the both worlds. So our case shows 6 weeks post-operatively. This is good alignment of the axial view and also the rafting plating of the articular surface. This is 18 months post-operatively. The patient's function is good. So why we choose 2.7 millimeter plate? Because at that time, 10 years ago, we don't have the other plates. So we found that this is suitable for the articular surface for the rafting technique. And we also use the 4.5 millimeter screws. This is for the axial screws for the medial column, also lateral column. So lateral rafting of the articular surface is very important. This is more stable. And also axial screws for medial column and alignment is very important. And the Merker in technical also will also publish their experience for the axial view. And a lot of papers discuss about the biomechanics for the axial view. Screws is very important for the alignment. And this is a 24 years male. Also, we kind of found that this is the simple tongue type fractures. And the colon will find that this is maybe just a sentence type A. We also do the STA and distract the articular with the distractor. Then we find the fragment. Then reduce with the KYs. And finally fixes with the 2.7 plating. And also axial screws for the alignment. So this is 90 months post-operatively. It's a good alignment and a good union of the fracture and a good function of the subtalar joints. So this is the paper published about the plating of the calcaneal with the triple plate technique. They also use 2.7 millimeter, and the result is good. 10 years ago, we don't have such kind of wave plate in China. So we want to do some design. So for special the design plate for the STA, and the function is for the rafting of the articular surface. But for the body of the calcaneus, we should use the closed technique deduction and the screws fixation. And we also have the Chinese patent 10 years ago. And this is our plate. This plate is not articular surface, also for the cuboid joint surface. And we also do the study also by Biomechanics, and also do some anatomical research for such kind of plating. And this is very safe for this kind of approach. And then this is the plate, the sample, the final, the products 10 years ago. So this is 51 years male. This also we found this is tongue type fractures. And this colon view set is Sinus type 2. Then closed deduction and the deduction of the posterior facet with the STA, also with our plate, and the axial view, axial screws for the alignment and the stabilization of the medial colon and lateral colon. This is the final results and good alignment and which is stable. We publish of the results in our Chinese literatures. So why we choose a MIS? This is a trend, and the function is good. It's quick for recovery, and quick to return to normal activity and life. So indication of the MIS, I think this is simple Sinus type force. This is a paper also from China, by Chinese doctors. They also publishes for the STA approach for Sinus type force. The results is good. So what about the timing of the MIS? I agree with the Gavin. We should do as quick as possible. No need for the wrinkle tests. Should be within 2 weeks. Otherwise, they're difficult for reduction and more complications for soft tissue. They also a lot of papers for the evidence-based for the minimal invasive. It's a long time, and also good results for the minimal invasive surgery. And what about the sanitized approach? This is, I think this is most choice. What about the complication? Also, they have some complications. If the patient have diabetes, this is not good results. And also, we should pay attention for the perineal cerebral complications. And also, there's some papers about the results of a minimal invasive surgery or the tensor lateral approach. This good results for the minimal invasive and the low complication of the soft tissue. How to do the reduction? We should do some, we should need some techniques. We use the KYs for the joystick approach. And sometimes we use the femoral distract or use the point clamp for reduction of the tuberosity, and also avoid of the wireless deformity. And this paper also of Chinese doctors just discuss of the media distractions is good for the wireless deformity. And we can use the close reduction technique with the KYs. This is from Buehler, and offer the exacerbation technique for the tongue type or Sinus type 2C. And in this book, Minimal Invasive Surgery in Orthopaedics, Dr. Cousy said, as far back as 1984, this Professor Ma in Regional Hospital in Shanghai, they published the approach with the combined for the manual manipulation of the heel with percutaneous poking of the fracture fragments. And this is a typical technique with the KYs, a joystick, and for the reduction of the posterior facets. And still arguments for the internal fixation, should we use the KYs or just the screws or small plating or big plating? The screw fixation is a traditional approach, just like Gavin have talked about, and sometimes just for the additional supplement of the plating. And it's very important for the articular surface. This is for the fixation of the constant fragment, for the tentaculum, and also for the posterior facets. And for screws, this is classical. And we also use for the axial longitudinal screws for the stabilization of the medial wall or lateral wall. But the disadvantage is it's difficult for the comminuted fractures or some cases of osteoporosis. And we maybe need more screws for screw technique. For what about the plating? Too many choice, and so what kind of the plate should we choose? And a lot of papers just discuss with the plate or screws, and the results is the two best methods is good results. And the basic principles for the choice of the internal fixation should be the fracture. We should discuss the fracture type and where is the main fragment, and also the doctor's experience. So what about non-locking or for locking plate? We should depend on the age of the patients, also fracture type, the bone quality, and we also think about the soft tissue and what kind of approach you should apply, and also the experience of the doctors. So we just look back at this paper. So what we have learned over so many years, minimal invasive may be the future. And the prognosis is unpredictable, especially for the intra-articular calcaneal fractures. This is a myth. So this is my conclusion. For the tarsi approach, this is minimal invasive. We should apply 3 points fixation principle. And the sustained teculum screw should apply the medial axial screws for the alignment. And the minimal invasive surgery is the trend, the future. And the important is the reduction. The alignment is more important than the articular surface. So what about the below approach? STA may be suitable for the simple Sinus type 2 or type 3. And there is good results with low complications of soft tissue. Thanks for your attention.
Thank you, Professor Shi. Now we will go ahead and take some time for questions. Professor Shi, can you please help to answer the questions which are being presented on the screen? Thank you.
Yes. So the question one is from Keck. What are the advantages of operation with the robotic machine in calcaneal fragments? This is a good question. You know, in nowadays, in the future, for the, you know, for some cases, we can insert screws more accuracy, and for the articular surface reduction, we can use the robotic machine to do just for the accuracy, yeah. And the question two for Thomas, how to get better exposure for the fracture with the sanitizer approach. As we all know, this is also we need a long learning curve for the STA because it's small adhesion, and we should maybe use some KY distract for expose the fragment positive facet. It's more clear, and sometimes we can use the arthroscopic zesty for the modeling the reduction of the fracture. So this is my answer.
Thanks, Professor Shi. It looks like we have covered all of our questions. Thank you again. So, Professor Shi, is there anything else you want to cover before this lecture wrap up?
Yeah.
So now, because now we are before our lecture ending, so do any other advice or the comments you want to deliver to all the participants?
No, thanks.
Okay, thank you. So now we move to our next lecture. So in the next, Dr. Martet and Dr. Sheikh will present on topic failed primary treatment of calcaneal fractures. What to do? Please allow me to remind you again. Please don't forget to type any kinds of your questions during the lecture or session area. We will collect and answer them after the lecture. Dr. Andoshe, it's your turn now. So please help to share your content screen by clicking the green icon, share content. Thank you.
Hello, everybody. From my side, I'm coming from the other world, from Europe. And I have to say that probably my topic is a little bit different. Why? We already heard this pendulum of calcaneal treatment in last 2 or 3 decades, from conservative to extensile lateral approach with all complications we know. And now we are in a phase when we are moving to minimally invasive surgery. I went through all these 3 eras, but I'm seeing more and more failed primary treatment of calcaneal fractures. And my topic would be what to do in those cases, what possibilities we have, and I will try to make decision-making for all these cases. We all know that among them, these fractures are among the most disabling of all fractures. And it was written that if they are untreated, they lead to substantial problems as a rule. And I add those 2 words, inadequately and badly treated. And I'm sure that many of these fractures are badly treated. Patients, after failed primary treatment, complain of pain, swelling, stiffness, limp, hindfoot deformity, and they have physical limitation on standings on their toes, walking on uneven ground, climbing ladders, and also in this time working as sport abilities. And these problems and complaints, limitations are connected to the soft tissue injuries, and I'm not going to talk about that much. And on the other side, to the bone and joint injuries. Let's just a glimpse into soft tissue. Smashed heel pad, can we do something? Almost nothing. There's injury of nerve, there is peroneal peritendinitis, which is very painful. And there are some consequences of compartment syndrome and sympathetic osteodystrophy. On the other side, we have bones and joints. We have flat foot, we have arthrosis, we have mechanical malalignment, and impingement, or better say abutment, which can be on the lateral side between the fibula and calcaneus, or anterior because the talus is retroverted, and there is connection between tibia and talar bone. All this means alter biomechanics of the foot. As always, we try to do something with our conservative treatment. We modify shoes, put some heel cushions in. We prescribe orthosis, drugs to decrease pain, physical therapy, local injections, or we modify their job environment. But many times this failed. And after that, after failed conservative treatment, we try to do something with operation. We want to relieve pain and we want to restore talocalcaneal alignment. We want to improve biomechanics of the foot. And how we do that? With reshaping of the hindfoot. What means reshape? And Ted Hansen wrote that the foot, to function as a foot, it must look as a foot. So we have to reshape the hindfoot. Calcaneal malunions was divided in 3 types in 96 by Stephens and Sanders. Type 1 with lateral wall bulge and arthrosis. And then we have a significant arthrosis, or arthrosis with varus or valgus displacement. I do prefer calcaneal malunions described by Tripp and Ramon because they are more elaborated. So we have different kinds of, and type 3, 4, and 5 are complex injuries. What we can do in cases where there is no arthrosis, so there is subtalar joint, and we have lateral impingement, we can try peroneal canalizes, but questionable result. We can remove the lateral wall, or we can make some kind of osteotomy. Removal of the lateral wall or lateral osteotomy or axial osteotomy was described by Cotton 100 years ago. What we are doing here, we are removing the lateral bulge, so we are making room for peroneal tendons, which are now at the anatomical position. But in all these cases, we have carefully selected our patients. And in many times, we are doing intraoperative arthroscopy to see whether the subtalar joint is there. And this is the case which most of these cases are referred. It was a simple fall in 71 years old lady, treated conservatively. And what we did, lateral osteotomy, we do our job with simple procedure. In cases where we have no arthrosis, but we have valgus heel, we can remake the basic fracture line. So this is oblique osteotomy, where through this obliquity, we moved the tuber back and distally and make room under the fibula. But be careful. If there is still displacement between the talus and the midfoot and forefoot, we are not doing exact thing. We can squeeze together the calcaneus. And this is a simple case of a patient with an open fracture, which was more or less overlooked and referred after 4 months. And here we still have subtalar joint, which is there, and we did just an osteotomy. We have lateral displaced tuber, protruding sustentaculum, shortening decreased Buller's angle, lateral anterior impingement, but preserved subtalar joint. So with combination of 2 approaches from the lateral and from the medial side, we did oblique osteotomy. We pushed together those 2 pieces. We used also elongation with femoral distractor. And this is the end result with good function. Osteotomy can be also osteotomy of the tuber, Dwyer osteotomy in varus heel. What we are making here. Here is a young lady of 20 years, intra-articular fracture, which was somehow treated with 2 screws. I really do not know where these 2 screws are. And this was the end result after 10 months. So varus heel and preserved subtalar joint. So what we did, Dwyer osteotomy is closed wedge osteotomy of the tuber, fixed with only 2 screws and with good functional result. This is clinical result. This was before, and below is after, with the function. And the function after 12 years is reasonable, it's good. But if there is painful arthrosis, we have to think about that. But the only thing is fusion. We try to preserve as much motion as possible. So we have to think of normal bone alignment, but with fusion. So in situ subtalar fusion is one option. But do we believe in situ fusion? I really do not. Why? Because we are losing 0.5 centimeters of bone in the posterior facet, and that means that we still have displacement between the talus and the navicular bone. In cases with arthrosis and varus or valgus malalignment, there are more possibilities. We can do a subtalar fusion with correction of the axial malalignment. It's quite straightforward procedure where we moved from the varus to the valgus or neutral position and fixed with just one screw. A really different story is with arthrosis and complex malalignment. What we can do here? What do we have here? We have varus heel, decreased heel height. We have lateral impingement. We have subtalar arthrosis. We have anterior impingement. So what to do? We have a list of problems which are enlisted on the left side and solutions on the right side. So we fuse if there is arthrosis. We distract if there is decreased heel height. We correct the angles if there is displacement. And then we excise wall which is bulged. And we restore the talocalcaneal angle relationship. This is the most important thing. So here we have two different options. One is subtalar destruction bone block fusion, described by Carr many years ago. And what we are doing here, we have horizontal talus here, we have arthrosis below, we have bulged lateral wall, which should be removed to make place for peroneal tendons. And then we open the subtalar joint, we remove the cartilage, the remnant of the cartilage, and with this, we can improve the position of the tuber calcaneal. And this is the case where we have a both side injury, and we did this kind of operation. We put to the right place the tuber calcaneal on both sides. Actually, we operate all hands because he had a fracture of both distal radius. And this kind of operation is quite straightforward. This kind of operation is a working horse for reconstruction of the hindfoot. So subtalar arthrosis, displacement, lateral wall is bulged, and we are going step to step. Here you will see that I'm using a lateral extensile lateral approach. And for this, I can say that when there is a failed osteosynthesis, if there is material in, you have a bulged lateral wall, you have to use extensile approaches. It is not enough to make just a Galli approach or something like that. Here is presented how the lateral bulge is in direct contact with the fibula, and there was a fracture of the fibular tip. So we excise that, this is fibula, and then we are going to open the subtalar joint. There are remnants of cartilage. You have to distract the joint to see directly to the medial side and to easily remove all the remnants of the cartilage together with a bone. This is the flexor hallucis longus, and you have to go to the medial side also to clean the medial facet, because otherwise the results won't be good. So fixation is then straightforward. Here is removal of the lateral wall bulge, which the lateral wall should be at the level of the lateral talus. It should be really on the same line. Correction of the talocalcaneal alignment is doing under the image intensifier. You open the joint, and now there is a gap which should be filled with bone graft. Mostly we are using bone graft from the pelvis, and it should be cortico-spongiatic bone. It's a big piece which completely obscures the subtalar joint. Many times it's really stable. So for fixation, you need a screw or two And in last years, we are using also the cannulated screws. Here it will be presented with normal spongiotic screw, which is still useful and of course cheap. You fill the subtalar area completely with spongiotic bone, and here is the fixation, which is really straightforward. As you again see, there is extensile lateral approach. And with correction of the hindfoot, I think, and I feel that in my hands, minimal invasive surgery has no place. It is very difficult to correct the position of the calcaneus without opening the field. You can do that if there is only simple subtalar arthrosis. And this is the most important thing here, that you have room for peroneal tendons. In complex malalignment, the other choose is reconstructive subtalar osteotomy with subtalar fusion. What we are doing here, we compose the previous operation, bone block fusion, with oblique osteotomy of the tuber. So we are gaining length. But many times you have to use double bone blocks of different height to have the real position of the hindfoot in your neutral position or in slight valgus. And this is so-called ankle sprain. This is fracture dislocation of the calcaneus with subtalar joint, which is not preserved, is injured. In all complex injuries and reconstructive surgery, it is very useful to have a 3D reconstruction of the complete foot, because then you understand where the problem is. Here you see the lateral abutment. Then the tuber is completely on the lateral side. And if you want to do that reconstruction, you have to insight into subtalar joint and also the shape of the calcaneus. How to do reconstructive with osteotomy? Again, I'm going to use extensile lateral approach. We can talk about that later on. But if there is a bulge of the lateral wall, for me, it's impossible to make through minimally invasive surgeries here. Here we are just on at the top, and then you open the subtalar joint. You clean the subtalar joint. Here's the direct connection with the fibula. It is impossible to see in the joint, so you have to use some shunt screw to open the joint or distractor to open the joint. Removal of the lateral wall. So again, we are composing two different osteotomies. One is removal of the lateral wall. Then we are going to make oblique osteotomy, as we did at the beginning with the preserved subtalar joint, but we will end with subtalar fusion. This is oblique osteotomy. Here, I'm doing that just through the lateral approach. At the beginning of my presentation, I show you how to do it through two approaches from the medial and lateral side. And in that case, you can use, of course, much smaller approach. Here is removal of the lateral wall, the upper side. And after osteotomy, oblique osteotomy, we are removing the subtalar joint. And then we are going to distract the tuber from the talus, which is in horizontal position, but we will lift the talus up, derotate it. Here I'm just putting some K-virus in to see the position of the osteotomy, which is done under the image intensifier. Osteotomy with the saw, in case that it is translation of the lateral of the tuber, Then you can make 2 cuts, remove the middle part. You can use that for bone graft in the subtalar joint later on, if the bone is very good. The main point is to squeeze together the tuber, to lift the tuber downwards and backwards to the anatomical position, and then we will finish the work with subtalar fusion, which is again done by just few screws. So fixation is minimum. We are using minimax how to say, philosophy here. Use small screws and fix the subtalar joint with a good bone graft. Biology here is still important, despite that the calcaneus is healing very good. So we can jump a little bit quicker here up. So squeeze it together, fix it with screws as before. So we are combining osteotomy and removal of the lateral wall and cleaning of the subtalar joint with subtalar fusion. Okay, I think everything is clear here. So what we did? We did subtalar fusion together with oblique osteotomy to move the tuber to the right place. And this is the result after 2 years and functional results at that time. The lady is back in her garden and he walked me around. Here is presented what we did. We combined 2 different osteotomies to get a good result. Many cases are coming with infection, arthrosis and complex malalignment. And in these cases, we are using stage procedure and we can get a quite good result. This is gliding sportsman with dislocation also in the midfoot and the forefoot. And after 12 years and after 15 years, the outcome, after open complex fracture, I think is reasonable result. It's always the question when to operate. If there is preserved anatomy of the hindfoot, you can wait for a while. But if you have a severe deformity or failed surgery, do not wait, go on. Longer we wait, later or never, this patient will get back to work. Diagnostics. Physical examination is still very important, and this should be static and also dynamic. Look at the patient from the back and ask them to step on their toes, and you will see the position of the hind foot much better. Radiology will confirm that. We are using standing lateral foot and Saltzman view together with 3D and 2D reconstruction. Use all documentation. First pictures after injury are extremely important. Weight-bearing views. Saltzman view, this is prerequisite for doing this kind of surgery. So what about the outcome? We do, I think that 160 cases now, but this is from the literature. We can improve the AOFAS score quite well. We relieve pain, but this is usually not complete. Some are, the others not. Many patients are extremely satisfied with their results because they really suffer after this kind of displacement of the hindfoot. You also can use dynamic pedobarography because this will show you return to normal of the pressure distribution under the feet. What do you think about this? This guy was mountaineering in Himalaya. Actually, he's died, but not of this kind of injury. He was operated. This is in Latin and means nothing worse than lost hopes. So these patients have hope how to improve their results. Doesn't matter whether they've been primarily treated operatively, conservatively, or if you want, with limited minimally invasive surgery. And greatness of our work is in tiny details. I try to present you all these details through this presentation. And I think that there's no need to tell you who's the gentleman here who learned all of us about this kind of surgery. That's Hans Sweet. Thank you very much.
Thank you, Dr. Andrzej. We appreciate your shares. So now we will take some time to discuss the questions from participants. Here are some questions we collected. So next, Dr. Andrzej, can you please help to answer the questions on the screen? Thank you.
Infection after extensile lateral approach is more or less a problem of the hematoma. If there is a question of hematoma, I would suggest to immediately open up and to clean it, to wash it out. And in my hands, that works. So we had no problem with infection after removal of the hematoma. Otherwise, we are using some antibiotic beads. Of course, there should not be any artificial bone there for bone block or something like that, because in that situation, you have to remove it. And then after decrease of infection, you can put autologic spongiotic, not corticospongiotic bone in. The guy I presented, that climber, had this problem. He was operated somewhere else, and he had a fusion just 10, 11 days after removal of the dead bone from his heel. I did not operate that operation. I was very astonished about that operation. It was done by Professor Tripp. I would wait a little bit longer. I would do that after changing antibiotic beads once or even 2 times, and then I would close the subtalar joint with a kind of fusion or osteotomy. Varus, in case of postoperative varus deformity, which degree can be accepted? In one sentence, varus is bad, valgus is good. So I wouldn't accept varus. For me, acceptable is neutral position, but not varus position. Varus is quite simply to decrease or to remove with closed patch osteotomy, as I showed you before. So no varus in all these cases.
Dr. Andrzej, thanks for your answering. It looks like we have covered all of our questions. So, Dr. Andrzej, is there anything else you want to cover before this lecture wrap up?
In this issue, I would say that I was trying to tell you that if you are going to operate calcaneal fracture, the primary operation should be almost, let me say in brackets, perfect. Because it's much, much more difficult if you have already there material or a kind of problem with bone healing, infection, or anything else. It's easier to do that after a conservative treatment than after operative treatment. And my experience is that many people are coming with inadequately treated, operatively treated calcaneal fractures. So if you want to operate calcaneus, do it well.
Okay, thank you. And Dr. Dr. Andrzej, we appreciate and thank you for your shares and your advice. So thank you again. So
thank you.
Next, thank you. So next, Dr. Hong will present our last lecture with the topic surgical pointers of calcaneal fractures. Just a kind reminder again here, if you have any questions for speakers about lectures, don't hesitate to type name on the chatting area. So Dr. Hong, now it's your turn. So please help to share your content by clicking the green icon, share content. Thank you.
Thank you. Yes, Dr. Hong Jia Liang or Dr. Ang, as I'm known in Singapore. So I think we've had three very excellent talks, certainly very complicated problems and issues shared by Dr. Andrzej. And so just to round off the whole session, I just wanted to share some of the pointers which I've learned over the years. Of course, many of these has been covered, but just as a roundup. And so hopefully with some pointers, some more careful way of fixing calcaneal fractures, we can avoid some of the problems which we've just seen. So I do a lot of sports, joint replacements, but I do a fair number of trauma too. So let's go ahead and look at this. I think the importance of the calcaneal bone is well known here already by everyone who's attending this webinar. It's been observed more than 100 years ago that somebody who breaks his heel bone is done, can't work anymore. And certainly it's still the same sort of situation, the same case, even for nowadays. So as with any calcaneal injury, standard assessment, I won't really go into. Everybody knows how to do it. For example, things like mechanism of injury, the wounds, swelling, soft tissue condition. And for me, I always ask them whether they smoke. And then we go on to do x-rays, including lateral views, axial views, and Broden views. I do CT as needed if I think that it looks complicated, not the simple Sanders tool. So for simple Sanders tool, I don't CT. So sometimes I fix calcaneums without CTing them. At this point, I just want to share a little bit of what I learned from the literature. I think the truth is that it is still almost quite wide open. What is the optimal treatment for calcaneal fractures? There are many papers, tons of papers, and people have done meta-analysis, Cochrane reviews, and most of the conclusions really is nobody can really tell for sure what exactly is better. But I've picked a few which looked more relevant. So the first one is by Ning Wei and others. It's a meta-analysis, 2017. They find that surgical treatment of displaced intra-articular calcaneal fractures, certainly it restores anatomy better. And because it restores anatomy, there is less shoe wear problem and there's a higher return to work. But of course, because we operate, complications are higher. The second one, Cochrane review in 2013 by Bruce and Sutherland. Operative treatment has less likelihood of subsequent subtalar fusion because of less likelihood of arthritis. And also surgery can allow the patient's faster return to work. Again, it has higher complications. Last one I found, prospective multi-center RCT in 2013. At 1 year, they concluded that surgery is not superior in terms of pain, in terms of function, AOFAS scores. But in the medium to long term, surgery is associated with lower pain and less subtalar arthritis. So I think for the right patient, certainly there are some benefits to surgery. And so in my mind, the benefits or the goals of surgical fixation are mainly these three. First is to restore the subtalar joint. to reduce arthritis and pain in future. And so we're not looking at 1 or 2 years down the road. We are thinking about 10, 15 years down the road. And so that is something I will frequently help the patient to understand. It's not that it's not that we're saying that we can reduce pain 1 or 2 years later, but it really is something about his future. And we want to correct various alignment and reduce any lateral blowout. And really the goal of doing this certainly is to allow proper shoe wear. And of course, avoid all the complications and issues which we just saw just now. And while doing this, while fixing it surgically, we want to minimize complications like infection and wound healing problems. So let's just go ahead. I'll just show you some pointers which I've learned over this time. I think one of the things, well, different surgeons do it differently, but for me, how I put my C-arm over the years, I've come to put it just directly in line with the bed. So I put my patient on lateral position, and I use a sterile towel pack. I make sure it's a sterile towel pack, not a non-sterile pillow, so that it's easy to adjust the towel pack during surgery. I can move it away for the x-rays, and I can bolster it up for better support. So I bring my C-arm in with the base parallel to the bed at all times. And over time, I think this helps me. I don't have to think about where my C-arm should come in or figure out how to do the view. So to get a lateral shot, lateral view is easy. Just come in straight and you have your lateral view there. There it is. To get an axial view, I will put my C-arm horizontal and I'll rotate the arm. So like this, I'll rotate the arm like this and dorsiflex the ankle, and that gives me a very good axial view, I find. And to get a Broden's view, same thing, the C-arm comes in line with the bed. So what I do here is that I will externally rotate the leg about 45 degrees. So this is effectively equivalent to internally rotating the ankle about 45 degrees relative to the C-arm. And then I'll put my C-arm at 10, 20, 30, 40 degrees as necessary to look at the subtalar articulation. So when I do an extensile lateral approach, just a few pointers which I just want to point out. I think we all know that we have to dissect full thickness flaps. I make sure that retractors, if any, are into the deep layer, into the periosteum. So I don't like them in the subcutaneous flap, the subcutaneous fat, for example. And when we close the skin, I always make sure we have to evert it properly. I don't accept any inverted skin closure. Sometimes if assistants close, they close it a little bit inverted. I redo them. Because when we invert the skin, we effectively reduce a lot of the surface area for subcutaneous healing. And most times I do it just in a double layer closure. And just by doing this, I find that, you know, in my cases, I haven't had any infections with an extensile lateral approach. Sinus tarsi approach, I use an II to mark my incision. I make a cut like that. And I dissect subperiosteal, retract the peroneal tendons, usually inferiorly, and we should have a pretty good view of the subtalar articulation. So reduction, I do it just a little bit differently. Most surgeons or many surgeons will use a shunt pin in the posterior tuberosity. For me, I just use two mmK wires. I drive it through the calcaneum from lateral and it comes up medial. So I use it almost like a bicycle handlebars. And I use that to manipulate and pull the calcaneum out to length. Of course, we will need to use instruments within the fracture line itself to help pull out the calcaneum. Sometimes I put K-wires too in the cuboid and do a sort of like traction. So I find that I don't really use like an external fixation device. Also because I tend to be able to get to them probably early enough within the first 7 days or even 14 days post injury. I think it's possible to reduce it like this. Having pulled out the calcaneum to length, the next thing to do is posterior facet elevation. And I do this just by inserting a paraosteal through the lateral wall fracture line and to push up the posterior facet. And I take care to preserve cancellous bone that is just beneath the articular surface. So I don't want to be pushing so much or pushing so forcefully that I push out all the cancellous bone. And this is important to make sure that there's still some cancellous bone that is just subarticular so that we can put our cannulated screw there. And I reduce the medialmost fragments first and check prudence views. And so once I've reduced the posterior facet, I fix it just using cannulated screws with washers. I have used headless compression screws before, but I find that that's not a very good idea because if the day comes where you have to remove a headless compression screw, you will need II and you will definitely need to take off bone from the head, a bone around the head of the screw, because bone is just going to grow all over the head of the screw. And then I align the posterior tuberosity and fix it to avoid any varus malalignment. And then the last step I do is what I myself call fragment-specific fixation. If there are fragments, if there are fracture lines in the posterior tuberosity, big enough and displaced, certainly we can consider fixing them. So we just look at some illustrations. And most of these cases nowadays, I do it MIS because I find that it works in my hands. It's enough to get a good subtalar reduction. And let's look at them. So this is Sanders tool with marked posterior facet depression, varus alignment, and through MIS Sinus tarsi approach, you reduce the posterior facet and fix it with cannulated screws. Now the screws should look like they're going a little bit anterior, just something like that. And another case, I like my screws looking like this. They should look like they're going anterior and just look nicely parallel like that. So that's the best kind of look I like. Sometimes my screws look like this, but I think it suffices as long as it fixes through sufficient cancellous bone to support the articular surface. You don't want to be fixing a void here, in which case it doesn't do much at all. And axial views. So for this case here, this patient had a tongue type posterior tuberosity fracture together with a fracture of the medial side of the posterior tuberosity. And I chose to fix it, just one screw each. And to fix this one here, it may not be as easy as it looks. And we may have to make, I had to make an incision on the medial side that's sizable, probably about 2 cm, to let me reduce this fragment and fix it with a cannulated screw. And my post-op regime, just to share a little bit, I make them non-weight bear, at least about 3 weeks, but then I'm fairly aggressive with weight bearing thereafter. So many cases, at 3 weeks, I will put them on an air walker boat, just like this, and they can start just light weight bearing with crutches. And I'll teach them to do passive range of motion and gentle wound massage, just even 5 days post-op. And this is because I find that a lot of post-op pain that persists for a couple of months, a lot of it is due to scar tissue formation, and especially in patients who find it difficult or are afraid to move their ankle, this is all the more important. So I encourage my patients to be active as soon as possible, mobilize and bleed as soon as possible. And thank you. I hope this has helped round up this excellent session of talks, and I'll be happy to receive any questions if there are any.
Thank you, Dr. Hong. Now we are going to take some time to discuss the question arise. Dr. Hong, can you help to answer the questions on the screen now? Thank you. Please wait for a moment. Yes, now we have the questions.
In osteoporosis, I think let's assume that like the patient is like 60 plus years old. I am still fairly aggressive, so maybe not 3 weeks. Maybe I'll let them weight bear with an air boot at 4 weeks, because I find that the most important is the fixation of the most important is that the screw is catching the cortex on the medial side, and the head is against the lateral wall. So that's the most important. And they may be quite osteoporotic in the cancellous part, but if I'm sure that my screw is well positioned, is right below the joint line, then I'm happy to weight bear them even from 3 weeks. Second question is, are there any techniques for reduction of calcaneal fractures with displacement of the substantial tali, the medial approach, the combined lateral? So I think one way certainly is to make a combined medial and lateral approach. You can still use a sinus tarsi approach on the lateral side and make a small incision directly over the substanticulum tali, because that can be quite subcutaneous. You can feel it quite easily. A direct incision over the substanticulum tali, and you have to reduce it and make sure you check Broden's views, and also the axial views can give you information on whether you reduce it properly, and then you can go ahead to fix it. So yes, a combined approach.
Thank you for answering, Dr. Hong. It looks like we have covered all of our questions. Now, is there anything else, Dr. Hong, is there anything else you want to cover before this lecture wrap up?
No, that's all I have to share. I hope that's helpful to everyone.
Thank you. We appreciate it.
Thank you.
Thank you, everyone. Now, all of our agenda have been finished. We appreciate your participating. We will send you all the relevant links after the event, including the link to the webinar recording, which will be active for 3 days only. So please leave your contact information in chatting area or contact us via email, course@doublemedical.com. If you have any questions for the above lectures, don't hesitate to contact us by email as well. Thank you again for participating in today's webinar. We hope to see you again next time. Thank you. Thank you. Thank you, Dr. Andershek. Thank you.
Thank you for question B波。
什么 question B？
这个。
B 你定了 right？